Thanks for being here. So welcome to this evening's Masterpiece Product Theater. And this evening we're having conversations about severe low blood sugar and treatment options. And my name is Carrie Sparling, and I am CWD's editorial director. And I'm happy to be the host of this chat this evening. And I am joined by Gary Scheiner, who, again, logged on early, joined by Gary, who is presenting on behalf of Xeris Pharmaceuticals, and will discuss effectiveness, usability, and safety information about the Gvoke pen. And so, Gary, I have a bio. It's right here and printed out. I can read it for you, and you can pretend that I'm not doing that, or you can introduce yourself to the community using your own words. Tell me your preference.
Can you do an abbreviated introduction?
I can. Ready? Watch me.
Just what you know about me?
Oh, okay. Gary Scheiner is pretty awesome. He's had diabetes, I think, almost as long as I have, if not. When were you diagnosed, Gary?
85.
Right. So he's had diabetes a year longer than me, which is fine. So he wins. I have known him through CWD conferences and other diabetes events that we have done for the last 10 or 12 years. I find his presentation style to be extremely funny, but in such a dry way that you don't realize that you should be laughing at it until you're a slide past what you should be laughing at. So make sure you're paying attention, because Gary will get you with the zingers when you don't expect it. He's the owner and clinical director of Integrated Diabetes Services, which is located just outside of Philly, right?
Mm-hmm.
And how long have you been there?
Almost 30 years.
And I know that you're very fancy because you were named the 2014 Diabetes Educator of the Year by the ADA, and you've written a boatload of books. So many of them are back there on my bookshelf, which so many people in the diabetes community consider instrumental in helping them make sense of their diabetes. So whatever humility you have in place at the moment, we'll just rip it to shreds by saying that you are a pillar in this community, and we're very proud to have you on this evening.
Well,
So
thank you.
how is that?
My latest book, Think Like a Pancreas, 3rd edition, is currently #1 on the Insomniac's bestseller list. So go out and get it.
Is that true?
Oh yeah, it'll make you fall. You'll be asleep in no time.
So here is where I will let you take over. I know you can share your slides and say hi to everybody who's here in the chat. We have a lively group. Sorry again to everyone who had to hear the prattle from before, but I am going to turn my video off while you're doing your talk, and then once you're done with your formal presentation, then we'll jump on and do some Q&A. But for folks at home, while we are doing this discussion, please make sure that you're putting any questions that you have into the chat or using the Q&A function so that we can make sure that Gary is addressing all of those concerns and questions throughout the course of the discussion at the end. So Gary, I'm going to disappear, but I will be here to spy on you, and I will turn my video back on once you've completed. Are you good to present?
Okay.
Go for it.
I'm going to switch over to a share screen in a moment. This is a topic that's very near and dear to me, having diabetes for 35 years, and I've been pretty aggressive with my management for the vast majority of that time. So I've had my share of low blood sugars. In fact, it's a topic so dear to me that Laura Bilito at CWD asked me years ago to develop a presentation specifically about hypoglycemia. So I got through about half of my presentation the first time I did it. And I started to get a little shaky and jittery and started to sweat. You know how it kills your credibility when you get a low and you're lecturing about how to prevent low blood sugar? It's just not a good thing. But what we're going to talk about tonight goes beyond the garden variety low blood sugars that we experience day in and day out. We're going to discuss something a bit more serious, which are severe hypoglycemic events and some new ways of handling them and dealing with them. So let me do the share screen. I will get this presentation up. Beginning, there we go. Okay, so hopefully you have this in the know with Gvoke slide up. Now, in my own sordid history, I've received glucagon twice, and it's been at least probably a good 25 years since I've needed it. Pump therapy helped me a lot to avoid lows, and lately CGM has made a big difference. But as we'll talk about in just a little while, severe hypoglycemia remains a pretty serious problem for people with type 1 diabetes. So what we're going to discuss, we'll talk about glucagon, why it's a very important thing. First off, in terms of glucose regulation in people who don't have diabetes, two hormones, insulin and glucagon, are constantly kind of balancing each other out. You know, insulin is produced when the glucose is rising, glucagon is produced when it's falling. In people with type 1 diabetes, though, when glucose is falling due to the presence of too much insulin, glucagon isn't produced. Insulin kind of blocks the production of glucagon. Glucagon is normally made by the pancreas, the alpha cells that sit right next to those beta cells that make insulin. And insulin inhibits the secretion of glucagon. So that's why severe low blood sugar can take place in people with diabetes. When I describe this balance between the two hormones, I draw an analogy with a car where you have an accelerator and a brake that are used, intermittently depending on the situation. Obviously, if you need to speed up, you hit the gas. You need to slow down, you hit the brake. And it's the same thing with glucose control. You need to bring the blood sugar down, you use insulin. You need to bring it up, you use glucagon. So hypoglycemia takes place in various phases. I refer to mild low blood sugar as garden variety lows. These are lows that we might experience routinely, day in and day out. Now, hopefully not too often. With most of my patients, I strive to keep the hypoglycemia to a minimum. But if it happens a couple of times a week and it's mild and easy to treat, that's usually acceptable. It's really challenging to eliminate 100% of hypoglycemia because there's just so many variables we have to contend with. But when glucose levels dip below 70 milligrams per deciliter, that's when the body will mount a reaction to it. That's when adrenaline begins to be produced. And that adrenaline causes the symptoms of the shaking, the sweating, rapid heartbeat, and it also drives hunger. Those are traditional early warning signs of hypoglycemia. Technically, the body doesn't suffer until glucose levels get down into the low 50s. That's the point at which the mind isn't able to get enough glucose to function properly. So that can lead to some behavioral changes and confusion. And I've heard really interesting stories about erratic behaviors people exhibit when their glucose is low. So it's very common for people to act a bit strangely, but you're still conscious. You can still treat it, even in what we call a moderate or a really low blood sugar. A severe low, we define as a low glucose that requires some intervention other than food, either because the individual having the low isn't conscious, they may be having a seizure, or they may be conscious but unable to consciously take food and drink it or eat it because they're so confused about what's happening. And that's a situation where glucagon is the only thing that should be used. Early on with those lows, we can use rapid acting carbs, but glucagon is necessary if someone isn't able to consciously eat or drink. It's dangerous to try to feed somebody who's having a severe low, because if they're not able to coordinate their own movements, they could easily choke on whatever's put in their mouth, and that could lead to suffocation. So it's not recommended to force feed somebody who's not consciously able to eat or drink. Let's look at the history of glucagon. Uh, the original glucagon kits that were designed by Lilly, Novo Nordisk has one as well called Glucagen. This was introduced 70 years ago. Now, think about how many things have changed in diabetes in the past 70 years, how insulin has changed, how insulin delivery with pumps and pens and smart devices have come along. Think about how glucose monitoring has changed with continuous glucose monitors, et cetera. So there's been a lot of R&D, a lot of new improvements in the treatment, but glucagon's pretty much stayed the same for about 70 years until just this past year. In this past year, we've had 3 new glucagons introduced. One is the inhaled insulin called Baqsimi. Another one was a pre-mixed injectable glucagon. And the third one is the Gvoke HypoPen, which we're going to focus on a bit more today. So in terms of glucagon, the one thing I will show you, if you open up the kit, there are instructions in here. The instructions for administering glucagon, I'll tell you, there's a lot more than 6 steps. whoever designed this slide tried to do a summary of everything, but here's the instructions. I don't know if you can see the size of the print on here, but anyone who's going to follow something like that in a state of emergency has got to be Joe Cool and brilliant as anything. Very few people can learn this and administer it in an emergency. The research has shown that more than not even 1 out of 3 people who's been trained on it can actually administer it in a crisis situation. So just having the glucagon kits for the most part didn't help because people just couldn't use it when the time came. A lot of steps involved. You had to inject fluid into a vial, you had to mix it, you had to draw it back out. And then the injection was tricky as well because of the size of the needle that was involved. So suffice to say, it was not an ideal product. And people who had it often couldn't use it anyway. So that was frustrating. The latest and greatest that we have in treatment of severe low blood sugar is this glucohypopen. It's like it says on screen, it's ready to use, it's already pre-mixed. You never see a needle with this. It's got an extremely good track record and it's very effective. And I'm going to do a quick demo for you with this. All that's involved in giving an injection with a Gvoke HypoPen is pulling off the red cap, finding a spot on the body to inject. You push down, you wait about 5 seconds, and that's it. There's a color in the window that turns red when the full dose has been delivered, and that's it. The needle's never even seen by the user. It retracts after the injection is complete. And this thing's approved for ages 2 and up. So again, to summarize, you pull off the red cap, you push the yellow part, the end, into the skin, and you just hold. It automatically injects. You don't even have to push a plunger. It does the injection on its own. And this can be given pretty much in any area where there's a little bit of a fat pad. So the upper arm, the abdomen, the thigh, those are all fair game for giving an injection of Gvoke. Now, when should it be used? Now, on the right side, you'll see, if you're having if someone's passed out or is having a seizure or is unresponsive, clearly that's a traditional situation for giving glucagon. But with something like this, it's feasible to give it to yourself in a situation where you can't get food or drink to work. So, for example, if you have a stomach flu, if you're vomiting, or if you have gastritis and just an upset stomach and your food is not digesting the way it should, you can use this. If you're not able to swallow for any reason, if you feel like you're about to pass out, you can give yourself this. If you don't feel comfortable getting yourself food and consuming it, this can be used. So it's good for yourself and it's good for other people to have to administer. There's a couple of restrictions on it though. People who have adrenal tumors, pancreatic tumors, they shouldn't be using this, but those are rare individuals. For the most part, this is good for almost everybody with type 1 diabetes. And how well does it work? Well, in the studies involving children, it worked 100% of the time. I don't think they can improve upon that. It brought the glucose level up sufficiently to regain consciousness and eat and take care of things. In adults, it worked 99% of the time. And I would have liked to have been there to find out why it didn't work on that one person. I can't imagine what would have done it. There are some potential side effects. These are rare, but it is possible for these to occur. Blood pressure changes. I don't know why Gvoke would cause low blood sugar, but you've already got low blood sugar to begin with. It can cause rash, and very rare to see these kind of things or allergic reactions. The amount of the glucose rise is significant. It tends to raise the blood sugar about between 120 and 170 points. So if you're starting out with a glucose in the 40s or 50s, it's probably going to bring you up to the mid to high hundreds. It's a fairly short-acting medication, so it's not going to keep driving the blood sugar up into the night and into the next day. It's going to work for a short period of time. Common side effects, and I mentioned some of the uncommon ones before. Nausea is common. Now, this doesn't mean that the Gvoke or the glucagon is what's causing the nausea. Anybody experiencing severe low blood sugar is subject to become nauseous. It's a major stress on the body, and the stress hormone production in and of itself can cause nausea. Vomiting can also occur. Again, not necessarily because you're administering glucagon, but because your body's in a state of severe stress, which can induce vomiting. And in rare cases, we see headaches, elevated blood sugar afterwards, and pain at the injection site. It's very uncommon. And most people who get this won't be conscious, but even for those who are, only about 1 out of 33 experience pain at the injection site. So 83% overall of these side effects, at least in kids, were pretty mild. And in adults, about the same. 81% of the side effects were quite mild. Gvo comes in two different pen sizes. There is a pen for children under the age of 12 and under, who weigh less than 100 pounds. But anybody who weighs over 100 pounds or is over age 12 can use the adult version, which is a full milligram dose. So the half milligram size, and you can see the pen has red lettering on it. That's for small children. The blue one with the blue on it, that's for adults and larger kids. And it's important to keep in mind that even if you're using a sophisticated hybrid closed loop, a pump, a sensor, all this kind of stuff, anyone who takes insulin is at risk of hypoglycemia. Even with these technologies, things don't always work exactly right or as planned. And hypoglycemia is the number one adverse reaction associated with insulin use. I mean, there are other things, problems insulin can cause, but low blood sugar is far and away the most common problem we see with the use of insulin. And the research has shown that even nowadays with CGM, with pumps and the better insulins on the market, on average, 1 out of 3 people experiences a hypoglycemic event in the course of a year. So it's still a relatively common situation. And unfortunately, people who don't have the ability to treat it with a good glucagon kit are subject to having a severe prolonged hypoglycemic event. Yeah, and that can lead to irreversible brain damage. That can lead to going into a coma. It can lead to death. And even if it does get treated by paramedics, it's going to require a trip to the emergency room and some hospitalization. And we all know things can go downhill from there if you have diabetes in the hospital. So uh, obviously, this is a better option for dealing with this. And the things that can lead to hypoglycemia, I mean, many of these I'm sure you're aware of, but just things involved in the way we manage day to day. It's important to set appropriate glucose targets. Some people set their glucose target a little bit too aggressively. We generally set glucose targets somewhere between 100 and 140, depending on the individual. And the lower the target, the greater the risk for having hypoglycemia. Just not having adequate control, glucose levels that bounce around a lot. There's a lot of variability in a person's glucose. They're at a greater risk for severe hypoglycemia. Errors can be made with pumps. It's very easy to type in a wrong number, to enter the decimal in the wrong place, to enter the glucose where the carbs should go, or vice versa. These kind of things happen, and incorrect doses can be given. And likewise, even with injections, you may draw up the wrong amount or draw up the wrong kind of insulin accidentally. Stacking of insulins is another common problem where you may start to try to fix high glucose levels before the previous dose has really had a chance to do its job and clear. Most pumps will do a good job of calculating insulin on board and deducting that, but you have to trust your pump when you do so. And people on injections should learn how to calculate their own insulin on board. There are smart pens now that can do that, but even if you don't have that, you can follow a chart or a guide and see how much insulin on board you still have from your previous shot. And obviously, taking insulin without knowing your glucose level or knowing the direction it's headed, and you can remedy that by use of a good CGM. Some of the lifestyle factors that increase hypoglycemia risk. Physical activity is one of the biggies. Physical activity will often cause glucose levels to drop during the activity, but some can also cause a delayed effect and lead to glucose levels falling hours later. Missing meals can be a problem, especially for those whose basal insulin doses aren't set up properly. And that applies to people on injections as well as pumps. Your basal insulin should keep your glucose stable between meals. And if you have too much basal insulin, the glucose is going to be heading downward. Erratic schedules can contribute to problems, particularly traveling across time zones, uh, changes in sleep and work and activity patterns, etc. Most people think of stress as something that only drives blood sugars up, but a lot of stresses can cause the glucose to fall, particularly as stresses that have people multitasking and doing a lot of things at once that they don't normally do. Alcohol use is another thing that can cause a drop in the glucose, simply because it blunts the liver's production of sugar. And then certain individual factors, like people who are very sensitive to small doses of insulin are at risk. Pumps are good for that, but if you're not on a pump and you have to dose to nearest half or whole units, it can lead to lows. People who might become easily confused by the calculation of their insulin or when to take it. And speaking of the when to take it, that's another key. Uh, Having an understanding of things like glycemic index and the rates of food digestion is necessary to know when to give your insulin. Some foods digest very slowly, and it's necessary to give the insulin a little later than usual or to spread the delivery out over time. Having a history of severe hypoglycemia automatically puts people at higher risk. Having hypoglycemia unawareness puts people at a higher risk. Hypoglycemia unawareness means that you lose the ability to sense your low blood sugars. You don't get those early adrenaline warning signs, the shaking, sweating, things like that. The first thing you may notice is some disorientation. The length of time you've had diabetes plays a role as well. The earlier, the more recently you were diagnosed, the less chance there is. People who have had diabetes for many decades are at higher risk for severe hypos. And other health problems, such as renal disease, whereby your insulin may not clear from your body properly, can also contribute to lows. Hypoglycemia and severe lows can have a lot of other kind of side effects. Uh, Research has shown that 1 out of 5 people who take insulin feel terrified that they might pass out in public. 1 in 3 worry about driving. And what this can do is it can cause a sense of panic. It can cause some anxiety about managing your blood sugar. Instead of aiming for the targets that you and your healthcare team have come up with, you start aiming for higher numbers. You get nervous if your glucose even drops into the 100s. I've had patients over the years who have extremely consistent blood sugars, but they keep them all between 200 and 250. I mean, they've mastered it. They really know their stuff, but because of their anxiety over hypoglycemia, they just run their sugars too high. And obviously that's a problem. So it leads to not taking insulin, taking less than you should. So that's certainly a concern. Having good options for preventing the lows like CGM, and certainly good options for treating it like this Gvoke HypoPen, I think it's a good way to help minimize the fear and anxieties that could develop otherwise. Uh, Historically, glucagon has not been prescribed a whole lot. There's almost 7 million people on insulin, but annually there's about 600,000 glucagon prescriptions that are filled. So only 1 out of 10 people is getting their glucagon. And part of that, I think, is because we didn't have an effective glucagon kit. A lot of providers would say, well, they don't know how to use this in an emergency anyway, so why bother prescribing it? And I think patients felt the same way. Why bother having this if it's not something I'm going to be able to use in an emergency? So talk to your doctor about this. And again, it doesn't have to be your endocrinologist. Any physician, any nurse practitioner can prescribe this for you. So discuss with them the need to have a good glucagon kit. Gvoke HypoPen is something you should ask for specifically. And most healthcare specialists do feel that people should have glucagon and certainly have the ability to use it. Your practitioner may have a demo kit that they could let you try or let a loved one try. But again, the use of this thing, I'll show you again. You pull the cap, you inject it, don't even push a button, and you're done. So it's a simple thing to use. Compare it to where we've been, what we've had in the past. We have a 208-step glucagon kit with the big needle. We have, eating everything under the sun. We have, forcing food into someone's mouth who may not be able to consciously swallow it. We can call 911, in which case you'll end up most likely at the emergency room and spending an overnight stay that's going to cost a fortune. And who knows if they'll even know how to manage your diabetes while you're in the hospital. Or you can do Gvoke. Think about pump therapy. Back in the day, they were big, cumbersome, clunky, but I think most people now are comfortable with the way insulin pumps work and how we can fit them into our lifestyle. And I think we can say a lot of the same thing for this. It's a generational change in how we manage and treat severe low blood sugars. So again, if your doctor isn't bringing it up during your next appointment, you should bring it up. I usually talk to the partners of people with type 1 or the parents of people with type 1 to be responsible in making sure that you have this. But now with something that you could even self-administer, I think those of us who have diabetes should be the ones asking for this from our physicians. So this is a little bit hard to read, but I do want to share it's the second paragraph next to the young lady. I'll read this to you. It says, "We've all been taught that we never use glucagon on ourselves because it's only for use when passed out. Well, I didn't feel like I should just let myself pass out and then hope someone can save me. I took control and knew it was what I needed. So again, taking responsibility to deal with lows before you pass out. It's a good way to administer yourself. And I'm not going to play this. This is a long video about this gentleman explaining how his wife was able to save him multiple times because of severe low, and they had struggled before. He'd always ended up in the hospital. And now, with Gvoke HypoPen, she was able to administer it to him very easily. The company that makes Gvoke, Xeris, they have they have copay cards available. I'd encourage you to get a hold of those. If you go to gvokeglucagon.com, you should be able to find all kinds of resources to learn more about this, where to get the copay savings cards, etc. And I also wanted to share with you, if any of you have experience using Gvoke and have had a good experience using it, have found it to be helpful, the company is looking for spokespeople. They're looking for, I guess, testimonials, if you will. It's called My Gvoke Story at the pxgroup.com. Actually, I'll type that in so you've got it here. I'll type it in a moment. So we have some time now if anybody has questions. I'm going to turn off the screen share, and I'll type in the chat with anyone who has had a Gvoke experience they'd like to share. Put the URL here.
I rejoined you here, Gary. You have a lot of questions that came in while you were talking, so let me know when you're ready, because there were a couple that were pretty specific.
Okay, rock and roll.
And thank you for that. That was great, and it looks like it got a lot of people thinking in the chat. So let's just jump right in. The first question that we had was about the actual injection. So can it be taken anywhere in the body or just the thigh?
It's approved for use in the thigh, the arm, and the abdomen. I mean, I've had experience with patients using it in other body parts. It's the same with traditional glucagon. It should work, but the abdomen and the arm and the thigh those are the indicated areas for injecting this.
Got it. And
I mean,
then
I wouldn't stick it
oh,
in
go ahead.
someone's eyeball. That's not
That
appropriate.
sounds like a terrible
Most
idea.
fleshy parts of the body should work fine.
Got it. And then specifically about blood sugar numbers that you would want to be thinking about glucagon for. So someone had asked, at what BG number do you give it to yourself? Or I'm assuming a child.
I mean, I can be honest. I don't base it on the number. I base it
Mhm.
on the situation. I don't know about you, Carrie. I've walked around with blood sugars in the 30s and was
Mhm.
able to cope reasonably well. Not proud of it, but that you don't need it if you're able to function pretty well. It's when you're getting to the point where you're getting a little, your thoughts are getting cloudy, and you're afraid that you may not be able to get to the food and consume it. That's when you would use it on yourself. As far as giving it to someone who has diabetes, you would reserve it for situations where that person can't eat, can't
Mhm.
drink, is unconscious, is having a seizure. Those are the times you'd really want to use it. I mean, it can be used even if someone's conscious and capable of taking food, but I think it's a bit wasteful to use a kit like that for a low that could be treated with glucose tablets or some Smarties.
Yeah. And it's funny that you say that about sometimes I am just walking around completely lucid and fine at really low numbers, and other times it's a 65 that just takes me out, and it's so surprising the range at which I can function and be destroyed. So there's another question about hypopen over Baqsimi. So someone had asked, would you recommend hypopen over Baqsimi for a 5-year-old, and do you think it is easier to train or less intimidating for teachers? Kind of a two-parter.
Yeah, I kind of like this. I feel that, with Baqsimi, uh, I think it's easy to either over or underdose with it. With this, you're getting a fairly predictable glucose rise. And because it's getting into the bloodstream fairly quickly, it's pretty predictable and consistent in the way it works. And I think most people are used to seeing things like EpiPens, and they operate in a very similar manner. We don't think in an emergency of sticking something into a person's nose. We think of giving them a shot of something. This just makes giving that shot of something extremely easy to do.
Got it. And then what about that intimidation factor for people who aren't as in the diabetes bubble as you and I and so many people in the audience are?
I don't think there's much intimidating about this. You never see a needle. In fact, you only have to tell someone there's a needle in here. It'll still give the shot. It knows what it's doing. So, from that standpoint, I don't think this is intimidating at all.
And just personally, I find it less intimidating than the kits that we had when I was growing up because it just required reconstituting things. It was very complicated. So that seems less complicated, especially if your brain might not be
And
working
there's a
at full
lot
tilt.
that could go wrong, that can go wrong with these traditional glucagon kits. You could end up injecting air. You
Mhm.
could inject before it's in the needles in the skin. You might not mix it right. You may inject the fluid without getting the glucagon mixed in. There's just a lot of things that can go wrong. And in an emergency situation, you don't need things that can go wrong. You need a
Mhm.
foolproof system. This is as close to foolproof as we're going to get.
Absolutely. And then there were a couple of questions about changing insurance. So for people who have a prescription for the standard red box, like we were talking about before, what's that process like switching from one prescription to the next for this new kind of glucagon or this new way of administering glucagon?
I imagine it varies from plan to plan, but given that this is new, it's better. My guess is that most health insurance will cover it. But again, even if they don't, those copay cards are there for people who want to pay little to nothing to get one of these.
That's very helpful. And I'm sure if they go to that website too, that'll walk them through some of the mechanics of the different hurdles they might have insurance wise.
Yes.
Okay, cool. And I know you popped that in there too. And so we had a couple other questions. Someone had asked, can you talk more about your patients who would keep their blood sugars from that 200 to 250 range? This person says that they're the same way. What advice do you give for those patients that are running at at a higher clip?
Take baby steps. There's nothing that says you have to go from, you know, anxious about hypos, running in the 200s, to being little Miss Perfect Carrie and having glucose levels that are
I did
100.
not ask this question. I feel compelled to tell you this was not me pretending to be anonymous. This was an actual question from someone else. So,
I'm just using the Carrie generically, generically.
sure.
But yeah, make small adjustments. Maybe target 180 for a while, maybe target 160 for a while. That's okay. You got time. You don't have to make all the changes at once.
Hmm.
And I think a big thing is, if you don't use a CGM, a continuous glucose monitor that has live warnings, get one. I find that's extremely soothing to people who are nervous and anxious about having lows. You can set the threshold pretty much wherever you like and be alerted long before you're even within breathing distance of a low.
That's good advice. And then this is specifically about Gvoke and the stability of it. So, what is the lifespan of the HypoPen? And they had asked about ambient temperatures for storage. So, what are some of those details?
Room temperature,
Okay,
storage, and it's typically good for about a year, from the date you get it, give or take.
got it. And so it's out. It's okay out of the fridge for a year as well. You can keep it at room temperature for 12 months.
Yes.
Got it. And this is another question. So, say you administer Gvoke to yourself and your blood sugar starts to come up. Is there a need to go to the hospital? This person feels like everyone makes it seem like it's such a scary experience to use glucagon. So, what's the aftermath of that look like from a care standpoint?
Well, typically after treating a severe low with Gvoke or any form of glucagon, your glucose may actually run a little on the high side for a little while, but you got to be careful because you may drop again in the next 24 hours. Because something that this whole phenomenon does is it drains some of the glycogen storage in the liver. So your blood sugar may be a little bit on the tight side into the next day. So you just have to be a little bit cautious. It doesn't typically require you to be in a hospital to stay out of danger, though. Usually, once you're treated with this, you can usually have a little something, some normal food to eat, and get on with your life.
That's also good advice. And then this is a question that I was wondering about as well. Is it possible to give just a portion of Gvoke? The example that this person gives is if they have the flu and can't keep anything down, can half of a pen dose be given, etc. So what's that? Is there a microdosing option with this particular pen?
As far as I'm aware, there isn't. I mean, you might be, I don't even want to suggest
Don't.
ways to try to do that. The diabetes community is a resourceful bunch. If people can figure out how and it works for them, all the more power to them. But there's no proven way to do that right now.
Mhm. That's a very reasonable and safe answer. So thank you for positioning that very carefully. And there are a lot of questions about intimidation factors. So let's revisit that for a quick second. So when you and I were growing up with diabetes, diagnosed around the same time, the red box that we were given had like a mental sort of hurdle that you had to overcome when you were ready to use it. So what was it? Oh, is this the actual? So what was it like for you seeing what we did have and then these newer iterations? Oh, even the needle makes skin feel creepy.
Yeah, it's big, but typically people who were getting this were unconscious when they got it, and it was supposed to be injected into a muscle.
Okay.
Gvoke is injected into the fat layer under the skin, but it still absorbs very quickly and gets into the bloodstream fast. It's not like insulin that doesn't do anything for the first 15 minutes. This Gvoke gets into the bloodstream within a couple of minutes, and usually within 10-15 minutes, the blood sugar has risen substantially. So it still works fast, even without using an enormous needle.
And so it's your blood sugars going up and that sort of thing. Now, remember the old school glucagon kits, there was always that warning of nausea. And a couple of people in the chat have asked about nausea in terms of the Gvoke pen as well. So is there kind of a pukey aftermath to this, or not to be so coarse about it, but like what is that like?
Uh, like I said, about 1 out of 3 people experiences nausea, some degree of nausea. But again, it's not really the glucagon causing that. It's this rush of stress hormones that the body produced. You've probably seen in movies and whatnot somebody who's given this awful news, and the stress hormones just overwhelm them and they vomit. it's the same kind of thing. It's just a stress hormone response all of a sudden. Or even, athletes at the peak of competition might get nauseous, may vomit, right before the big event. It's the
Mhm.
same kind of thing. These are stress hormones that are causing that.
We had someone in the chat say yes, like when they found out they were having twins. So there's that stress hormone response.
Well, by the way, I was off on the stability of this. It's 2 years. So
Yep, I saw that that was added in the chat by a friend from Xeris. They were saying that stability is 2 years from the date of manufacturing. So that's good information to have.
yeah, but
And
keep in mind, you're not going to typically get it the day it was manufactured. You may get it several months, many months later. So you go typically till the expiration date that's printed on it.
oh, we have another temperature question. So a friend who is here on the chat says that they live in plus or minus 40 degrees Celsius temperatures. Will Gvoke live through this?
I don't think the person who wrote that, I don't know how they can live through that. Now, you shouldn't be exposing this to extreme temperatures, just like insulin. This is it's in liquid form in here. If it freezes, it's not going to be useful. If it boils, not boils, but if it overheats, it's not going to be useful. So generally, keeping it in the 80s to the 40s or 50s, it should be okay. But you can't freeze it. You don't want to expose it to really high temps.
And to that same end, is there a way to tell if it's, how you can look at insulin and see that it's gotten cloudy if it's
Mhm.
skunked up on you? Is there a way to tell that with this?
There really isn't. No.
Okay, so it's good just to keep it within the temperature range. That makes sense. And what about usability in terms of travel? So we have someone that's asked what kind of a case does it come in? Um, what's it look like shoved into your bag, or when you were foraging around in your couch for the pen? Like, what's it like to actually live with this thing on the go?
Well, it's about the size of a Sharpie.
Okay.
You think of it that way. Curved edges, uh, the cap that's sealed on there till you yank it off. So it's pretty sturdy. It's kind of crush resistant. It's not going to get pushed in accidentally.
Mhm.
So it holds up well, even in a backpack filled with all kinds of crap.
Excellent. That's a good real world example. Oh, we have one more question that just came in. Can people get extra pens of Gvoke with the prescription, whatever? Talking about having like an extra pen at a grandparent's house or at school, etc.
You
What's
can
that?
get
What's
two
that?
packs. You can get 2 packs of this.
Okay, so that would mean 4 in total.
Well, you can get it in a 2 pack.
Hmm.
And I suppose again, if you get copay cards, if you've got good insurance, you may be able to get more than a 2 pack in the course of a year.
I love these questions because they are so real world. It's not like, tell me about the molecular makeup of this. It's more, what bag do I shove it in? What real world scenario do I use it in? How do I live with this along for the ride? So I think these questions are great. Thanks to everybody at home for asking these. What is the cost? You might not know this one, Gary. Sorry in advance. What is the cost without insurance if somebody wanted to purchase extra as a backup?
I do not know, and I think it varies from place to place.
Hmm.
Uh, and the price is also going to vary depending on the insurance carrier, just like it does with insulin.
Got it.
But they're very generous with these copay cards, so take advantage of that.
That's good to know. And we'll make sure we post the link in the chat as well so that people can get more information. And another question that we have, do you recommend keeping the Gvoke in the package, so that pack of 2, or taking it out of the package to travel around with?
That depends on your personal preference. Personally, I would just carry it like this.
Hmm.
Takes up less space. There's fewer steps you have to go through to use it.
And do you keep the other one in a fridge?
Just at room temp is fine.
Room temp. And we have our friend from Xeris has popped in and said that it needs to stay in the pouch. So I'm assuming that's what it comes in.
Yeah, it's a sealed gray pouch that
Mhm.
like a bag of chips almost.
a perfect comparison. Great. This is great. And let me see if we've got any other questions. Well, there are no open questions right now. Gary, you've done a great job ripping through everyone's Q&A. So well done on that. And thanks to everybody at home for asking that. If there are any last minute questions to roll in as we're starting to wrap up the chat, feel free to pop them in. But Gary, is there anything that you would want to add for people who might be a little hesitant about trying something new? Because this is not hypothetical. As someone who's had diabetes for a long time, change can be intimidating, and switching from the one thing I'm comfortable with to trying something new can be a little bit of a mental hurdle. So what advice would you have for people who are getting ready to try out something new?
I would say, severe hypoglycemia is nothing anybody wants to have happen. But it is it's like an accident. You don't plan for accidents. Well, you prepare for them.
Mhm.
And this is a situation where even if you've never had a severe low, even if you don't think it could happen to you, well, it can. And they do happen to people with type 1 all the time. So it is necessary to be prepared. And this is, best way possible to be prepared.
Oh, and one other question. If someone's daughter, so I'm assuming a small child, is between 40 to 80, can they take the baby version of Gvoke instead of the adult version?
Well, that's the
Oh,
idea. If you're under 100 pounds, you should take the half milligram dose for
got it. So
children.
it's related to weight directly.
The fact is, I mean, if all you have is the adult version and you administer it to a child, I don't think it's going to kill them, but
Mhm.
it may produce more side effects, more nausea, etc. May drive the sugar much too high. So if you got a young child or small child, get the smaller dose.
Got it. And it's good to know that you cited the weight requirements too. So that's good just as a benchmark for what one that people should be using. Well, I think Gary that we have reached the end of your presentation and the Q&A. Just kidding. There's one more, so you can't go anywhere yet. We've had somebody say that they've had terrible hypos um, starting with, I'm guessing, in 1945. And what did let me just read this again. Sorry. What was I supposed to do without the devices we have today? No endos, no advice I could use. Oh, I think they're just talking about the really bad low blood sugars that they had before these tools came into play, and just what could a person have done
Well,
back then?
there is a lot of misinformation people are fed about dealing with lows.
Mhm.
Yes, I know they have this rule of 15. Personally, I found it not to work in most situations. It's better to customize your treatment to your body size and to the situation. You can't treat a blood sugar of 40 with the same amount of carb as a 70.
Mhm.
And you can't treat someone who weighs 200 pounds the same as someone that weighs 50 pounds. The bigger you are, the lower you are, the more carb you need. And if you're using a CGM and you're dropping quickly on top of being low, you're going to need even more. So it is important to customize.
You are getting many cheers in the chat for being awesome. So I will just second those and say thank you for joining us this evening, and just giving all of this great information, answering everybody's questions, and giving us your presentation. So Gary, and also for starting the chat early. I'm not going to let that go yet. So thanks for kicking this off 10 minutes earlier than we were anticipating and having some small talk with me. But I really appreciate, Gary, you joining us this evening for our Masterpiece Product Theater. And to everybody at home who has joined us for this discussion, just as a heads up, this recording will be made available after we process and upload it to our YouTube channel. We'll also be sharing it through our website. So you can always visit cwd.is/MPT for the latest on our Masterpiece Product Theaters. And if you want to hang out with us again for another chat, we have our screenside chats that also take place every other Sunday at 7 p.m. Maybe we can get Gary to join us for one of those too. But yeah, so there's always something going on, and hopefully we'll be eventually kicking ourselves off of Zoom and hanging out with one another in like a room somewhere, which would be
I can't wait for
awesome.
that,
I
Carrie.
know, right? It's been a long time. So I'm excited to see everybody at our next discussion and in person someday. And for now, enjoy the rest of your Tuesday night. And Gary, thank you again for joining us, and everybody at home. Have a good one, everybody. See you soon.